For the record, we have a quorum members today. We will be working on the Health and Human Services, the DHS policy bill with some additional provisions. Members, our intended path is to hear this language, amend on some provisions that we've agreed upon with the House, but I want to be transparent with the committee. And then we will lay this over, looking for final language on a minibus policy bill with the House. We'll amend those provisions on hearing any language that we haven't heard in this committee. For the committee's benefit, the work we'll do on Thursday will be language we've already heard that the House has agreed will be non-controversial. We'll send the delete everything language to Senator Marty and to all the members of the committee. And then there will be provisions that we haven't heard that we'll be hearing on Thursday to amend, and then we'll send this to the floor. And so with that, members, I would move Senate File 3560 to be placed before us. And because this is a department bill, we're going to have the folks from the department walk through the language. And for everyone's attention, at our Senate hearing site, this language is available along with the amendments that will be added on after we finish the walkthrough. And so let me see. We're going to go with the A1 amendment. So I'll offer the A1 amendment and ask that it be treated as an author's amendment. So all those in favor say aye.
Aye.
Opposed? Okay, thank you, members. And now to the A1 amendment, I have Ann Bobst from the department, Diego Hayes, Chelsea Jorgensen, and Gina Savage, I believe. And so I'm going to let the department decide who they would like to go first. If you could unmute yourself and orient us to the place in the bill that the place in the A1 that walks through your language.
Thanks, Madam Chair. Matt Burdick with DHS. I think I'll take point on walking members through the language, and then I might phone some of my friends here on the Zoom call as we go ahead.
I appreciate that.
If it's all right with you, Madam Chair, I'd like to just walk through the underlying bill, and I can point out as we go along where the A1 makes some changes.
Thank you.
Great. And thank you all for hearing our language today. Remember, some of this might be sound familiar, as some of this language has come before you in previous sessions. So I will walk through the bill, and please stop me along the way as there are questions. So sections 1 and 2, as well as some sections that we'll get to later on in the bill, are really intended to be technical in nature. Healthcare homes have traditionally been something that is under the jurisdiction of the Department of Health, but much of the statutory language actually is found in 256B, which is the Medicaid chapter of law. And so what these sections are intending to do are clarify the roles of our two agencies with regard to healthcare homes, as well as move the bulk of the language out of Medicaid statute and into the statutes that are under the jurisdiction of the Department of Health. And so this is something that we worked closely with the health department on, and is not intended to make any underlying policy changes to existing law, simply reworking the statutes to be clear about the roles of our two agencies. And so that is sections 1 and 2, and then I'll highlight where that reappears as we get through the bill. Section 3 relates to our state medical review team, also known as our SMRT. This is a team that it works here at the state to help people get disability determinations in order to be qualified for medical assistance based on having a disability. And what this intends to do is to reflect some work that DHS and the counties did to, again, clarify the roles of those two entities. So the way this works today is that a person will be present to their county and ask for a referral to the SMRT team. The SMART team then will work with that individual's medical professionals to help make that determination that they do indeed have a disability that would qualify them for medical assistance based on disability. And then that information is transmitted back to the counties. Right now, there is the way the current law is structured, it could be read that the county has to go and work with all those medical providers. And that was the way the system was working and found to be rather inefficient. And so this is intended to be clear that DHS is the entity that's working with the person's medical providers to gather the necessary information. Then the county is handling the eligibility determination. Section 4 is the first in a series of pieces here that we are trying to either add clarity in the law where there's been state policy made or reflect alignment with federal changes to make sure that that's clear. So Section 4 updates the reference to the federal definition of modified adjusted gross income. That's the main part of that section. Section 5 is intended to reflect the current medical assistance income limits for children, not making any changes to those. Section 6 is specifying that the timing at which someone's who is enrolled in medical assistance or is getting federal subsidies reports a change that makes them eligible for medical assistance, and making sure that it's clear about the timing of when their medical assistance coverage begins and their other coverage ends. Again, not intending to change anything about how that process works, but provide clarity about what the existing policy is. Section 7 is clarifying that medical assistance enrollees who have a spend down have their income reviewed every 6 months, but their actual eligibility is not renewed, only renewed once every year. There was some confusion about what that 6-month check was regarding versus what the full eligibility redetermination process is, which always happens on an annual basis. Section 8, this is adding some additional language about the processes that we've put in place to implement something the legislature passed back in 2017. There is a federal change that was made that requires states, for individuals who qualify for medical assistance and have an asset test, that those individuals have to agree to kind of a review using this, what we call account validation service, which goes and makes sure that there are not assets that the person is not reporting. And so this was a process that we put in place just to make clear about what people's rights are in terms of going through authorizing that review to happen and how that intersects with their eligibility. Section 9 is trying to put some more clarity into the state law about the timing and responsibilities of individuals related to periodic data matching. So this was something the legislature enacted a number of years ago, and we've got up and running in the past several years. And this is really intending to be clear about the timing by which someone has to resolve discrepancies if they're found to have information in the system that's different than what we have and that may impact their eligibility. What's the timing by which they have to respond and provide updated information? And then how does that time out in terms of if they did have their coverage closed when their coverage begins again once they've proven that they are indeed eligible? And again, this is trying to codify what we've had as policy, but making sure that that's clear in the law for transparency, as well as to be clear from an agency's perspective that kind of all of this is operating the way it needs to. Section 10 simply updates statute to reflect our current income limits for infants and pregnant women. Section 11 is trying to conform to federal law. Right now, when someone's in a long-term care facility, they're allowed to have a personal needs allowance. Federal law allows veterans who receive a pension to be able to keep whatever the higher value is. So if the pension is more valuable, they can keep that amount, or if the amount they would have had under their personal needs allowance was higher, they could keep that amount. And federal law allows the individual to keep the higher of those two amounts, and so we're conforming state law to make that clear. Section 12 is intended to clarify that the costs of a private room in an assisted living facility is not included in what's part of what we call a medical expense when someone is spending down in order to meet eligibility criteria. Sections 13 and 14 are intending to clarify that policy that hospitals must have a Medicare certification for the services that they are providing in order to bill medical assistance for those, and particularly intending to clean up some confusing language around organ and tissue transplants to make it clear that Medicare certification is what's required to perform those services. Section 15 has been removed from the bill as part of the A1 amendment. And then sections 16 and 17 are a continuation of the first provisions I mentioned, where we're moving the healthcare home statutes and clarifying the roles of the two agencies. Section 18 was also removed by the A1 amendment. Section 19 simply corrects an old drafting error. We had the wrong year tied to some updates to our hospital rate methodology for critical access hospitals. This, as I mentioned, there was a drafting error when this was first implemented. This is intending to correct that. Section 20 is clarifying that behavioral health home services are not covered under Minnesota Care. That has always been the case, and we're trying to make it clear in our state statutes that this is one of the services that's a Medicaid-only service that's not also covered by Minnesota Care. And then Section 21 is striking some old language. We have since codified our Minnesota Care premium schedule when those were increased in 2015, and then we codified that in 2017. And so this is removing some outdated language. In the amendment, there is a new Section 22, and this is the reviser's note that's doing the movement of these statutes related to healthcare homes, removing it out of Medicaid statute and moving it into the healthcare, the Department of Health statute. And then there is a repealer also tied to that work. So that is the bill, Madam Chair, and happy to stand for any questions that committee members have.
And questions from members. I'm going to open up my participant and chat window. I am not currently seeing any hands raised as to questions. So members, this was amended with the A1 amendment. There is, so seeing no questions, I know it's a lot to absorb, and Mr. Burdick did a very good job of walking through. So, okay, I've given a good amount of time for questions. If we could, to the A2 amendment that was in your packets. If you'll remember, Senator Draheim had a bill with transparency language in it. Let me see, I have a chat window. Okay. Senator Draheim had a bill calling for hospital transparency. One of the requests from the Hospital Association to help get through this time is that they would not have to implement that as of August 1st, 2020. And so I'd like to ask Senator Draheim, are you comfortable moving this date to the end of or to the 1st of January next year?
Thank you, Chair Benson, and I think it's a reasonable request, and I support it. Thank you.
Okay, so members, questions to the A2 amendment? Seeing no questions, if I could have everybody unmute, and I've been reminded that we actually need to unmute and give some sort of physical sign that we understand the motion and either vote for or against it. So we're on the A2. If you could unmute. Senator Draheim, would you offer the A2 amendment?
I move the A2 amendment.
All those in favor say aye, and
Aye.
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 any opposed? The opposite.
Aye.
Thank you. The A2 amendment is adopted. Thank you, members. And with that, we're going to lay Senate File 3560 on the table. We'll pick it back up on Thursday for further amendments, and we will try to get you that amendment as early as council has it ready, and then we'll have a separate amendment for any language the committee hasn't heard. So Senate File 3560 is on the table. With that, I believe we move to Senator Utke. Let me review. Senator Utke has Senate File 3121. We're going to hear this language today because it is the purview of our committee. We will likely include this in the language that we're going to move on Thursday, but for today, we're going to send it to the floor so there's a clear record of the committee's position. Okay? We have Senator Utke with us. Welcome to the committee. If I could ask Senator Marty, your mic is off. Could you move Senate File 3121 for Senator Utke? Thank you. Senator Utke, please proceed with your presentation. I understand you have testifiers. We can give them a little notice so they unmute. And members, this language, again, is on our committee page. So please take some time to look it over. Welcome, Senator Utke.
Thank you, Madam Chair and members. Senate File 3121 modifies a medical assistance requirement for persons needing breast or cervical cancer treatment. This bill would broaden state statute to comply with federal law and make sure any woman diagnosed with breast or cervical cancer through a CDC National Breast or Cervical Cancer Early Detection Program is automatically eligible for Medicaid for her cancer treatment coverage. Access to treatment and healthcare is critical to surviving cancer. 4,670 Minnesota women will be diagnosed with breast cancer this year, and 630 will die from the disease. 140 women will be diagnosed with cervical cancer. We want every one of these women, Minnesota women, to have the best chance possible to survive the disease. And details of the bill, it's a short bill, pretty cut and dried. So it's a federal law says any woman diagnosed with breast or cervical cancer through a program funded by the CDC's National Breast and Cervical Cancer Early Detection Program is automatically eligible for Medicaid for her treatment. Minnesota's Medical Assistance for Breast or Cervical Cancer Treatment Act is written with the most restrictive wording and names the Minnesota Department of Health's SAGE screening program as the only pathway to treatment coverage, leaving out any woman screened through CDC-funded programs. Narrow state statute means that women diagnosed through other CDC-funded programs in Minnesota aren't automatically eligible for Medicaid. Someday in the future, the CDC could fund screening programs in St. Cloud or Bemidji, and because of current state law, the women would not be eligible for treatment. Madam Chair, that's just a quick coverage of the what's in the bill. There is no fiscal note, and I believe that I saw Emily Myatt. I believe that's how it's pronounced, but I saw her on the screen as here and with us to testify.
And Ms. Myatt, you're on mute. Welcome to the committee. Please proceed with your presentation.
Thank you, Madam Chair and members of the committee. My name is Emily Myatt. I'm the Government Relations Director for the American Cancer Society Cancer Action Network, the advocacy affiliate of the American Cancer Society. I'm here today to testify in support of Senate File 3121, legislation to expand access to breast and cervical cancer treatment for any woman diagnosed with cancer through a specific CDC-funded program. We know many barriers exist to preventative cancer screenings and treatment, and that's why the CDC has funded states and tribal entities to screen low-income, underinsured, and uninsured women. Federal law says that any woman diagnosed through this CDC program is automatically eligible for Medicaid for her treatment. But like Senator Utke said, Minnesota state statute adopted this very narrowly and names only one CDC-funded program in Minnesota, leaving out women screened through other CDC-funded programs. For example, the American Indian Cancer Foundation receives federal funds from the CDC to do targeted breast and cervical cancer screening for urban American Indian women. Greener Circle is a program in Minneapolis working with the Native American Community Clinic to get more women screened for cancer. American Indian women are less likely to be screened and are more likely to be diagnosed at a later stage. Because state statute is narrowly worded, if a woman is diagnosed through the American Indian Cancer Foundation's program, she wouldn't automatically be eligible for treatment, even though federal law says she should be. The bill before you today focuses on making sure that women diagnosed through existing screening programs, both funded by the CDC with the same eligibility, have access to the cancer treatment they need. Many of these women would already be eligible for Medicaid, but we want to make sure that no woman falls through the gap. What good is cervical cancer screenings or mammograms if once diagnosed, you can't access the chemotherapy or radiation you need to survive the disease? By supporting this bill, you're making sure our state law conforms with federal law and that all women diagnosed through a specific CDC-funded program can access life-saving cancer care. You've received a letter of support on this issue from more than 20 organizations, including the American Indian Cancer Foundation, the Masonic Cancer Center, the Mayo Clinic, the Minnesota Association of Community Health Centers, and the Minnesota Medical Association. The Minnesota Chippewa Tribe has also passed a resolution in support of this bill. Thank you.
Thank you, Ms. Myatt. Let's go to questions from members. This would be your opportunity to amend the language. I am not seeing hands raised. And I'm not seeing any notes from Ms. Strand that members would like to speak. So Senator Utke, closing comments, and then Senator Marty, we will be moving this to the floor so I can make the motion. So Senator Utke, closing comments.
Thank you, Madam Chair. And I think for what's in the bill, it's a small bill, but a very important bill for the women of our state that have run into challenges with this program. And I thank you for the opportunity to present it and ask for your support. So thank you.
Okay. Thank you, members. I'm going to ask you to unmute and turn on your videos so that we can have a public record of your vote.
Okay, where are you?
Excellent. Got a couple more that we're waiting on.
Oh.
All right. Members, Senator Marty renews his motion that Senate File 3121 be recommended to pass and placed on general orders. All those in favor say aye.
Aye.
Aye. Opposed? Seeing none, Senator Utke, Senate File 3121 is passed and placed on general orders. So members, that concludes our formal business for the day. As you know, Senator Utke's bill is going to get snagged in rules. We are working with the House to see what their intention is with that bill. So we are going to possibly include it as language on Thursday, but we wanted you to have an opportunity to hear it before we have it show up in an amendment on Thursday. As we work with the House, we're going to try to come to agreement on not just bills that we've heard, but things that they have heard that appear to be non-controversial, and we will have them as separate language on Thursday. As we get agreement on language, we're going to send things to your inbox. We will also post it on the hearing notice. And if you could work through me, Ms. Strand, Senator Marty, and his staff, if you have objections, questions, concerns, so that we can deal with them as we're coming to Thursday. Our plan is to finish Thursday with an omnibus policy bill that will travel on the DHS policy bill, so we're not going to attach controversial things. I'll be the author of it. I won't be accepting things that I don't think are worked out. I don't want to take down the DHS policy bill and the other good things that we've heard. Members, the reason we're not doing this on the floor is the floor process for amendments, particularly if they get roll called, is much more cumbersome than having a bill come out of committee and have it voted on Thursday. So it's not that I don't want to accept amendments on the floor, it's that I'm trying to be as efficient as I can with members' time. And with that, I think Senator Marty, you are unmuted if you have any comments.
No, it seems like a fair process. I think it's a good way to go forward and
Okay.
finish up on Thursday.
And that would be my hope. I hope we don't need any Friday hearings this week. I know everybody is really busy and sometimes needs a catch-up day. So with that, seeing no further hands raised or member questions, with that, members, we are adjourned. I thank you for your time today.
Thank you.